All right, so we're diving deep today into something. You guys have been sending us a ton of stuff about pediatric autoimmune neutropenia, or EIN.
Right.
And we're really going to try to cut through all the noise with this one and really like hone in on like the key things to understand the differences between the primary and secondary forms, how it's identified, and really what it means for kids who have it.
Absolutely.
So let's jump right in and kind of set the foundation.
Okay.
What exactly is neutropenia?
So neutropenia, basically, it's just a low count of neutrophils.
Okay.
And neutrophils are a specific type of white blood cell that are super important for your body to fight off infections.
Right.
And we're mainly talking about bacterial and fungal infections.
Okay.
And so when you have a low count of these neutrophils, your body has a harder time fighting off those infections.
Makes sense.
And the specific numbers that we look at are an absolute neutrophil count, or ANC, of less than 1,000 per microliter of blood for infants, and then less than 1,500 for older kids.
Gotcha. So that's when those red flags come up.
Exactly. Yeah.
Okay. And so that kind of is the background then for both of the types of AIN that we're talking about.
Absolutely.
So let's dive into primary autoimmune neutropenia, or PAIN.
Okay.
What is the most important thing that we should know about this?
The most important thing to know about primary AIN is that it's benign.
Okay.
It's self-limited.
Okay.
And it generally affects infants and toddlers.
Gotcha.
So the typical age of onset is anywhere from 4 to 28 months of age.
Okay.
With a median age of around 9 months.
Gotcha.
You might also hear it called chronic benign neutropenia, or chronic idiopathic neutropenia.
Okay.
And what's interesting about it is that even though these kids have a low neutrophil count, we don't typically see a lot of serious infections.
Interesting.
And that's partly because when you're talking about these little kids, the infections they tend to get are kind of like what all kids tend to get at that age anyway. And they still have enough neutrophils to do a decent job of fighting off infections.
Okay.
So we see more mild infections.
Gotcha.
So that's kind of what's interesting about it.
Yeah. So benign and self-limiting, I mean, those are very reassuring terms.
Absolutely.
When we're talking about something with this scary sounding name.
Yeah.
So how long does this usually last?
So the duration can vary.
Okay.
But it's usually anywhere from 13 to 44 months.
Okay.
With an average duration of about 20 months.
Gotcha.
And the good news is that virtually all patients will recover before they reach 5 years of age.
Okay.
And many of them will recover spontaneously within 6 to 24 months.
Okay, that paints a very clear picture of kind of the timeline of it.
Yeah.
So how does this usually present itself in these little guys?
So oftentimes they don't actually have any symptoms.
Okay.
And a lot of times it's picked up on a blood test that was done for another reason.
Oh, interesting.
Like maybe they were getting a fever workup or something.
Okay.
But if they do have symptoms, they usually present with mild infections.
Okay.
So some of the most common ones that we see are mouth ulcers, gingivitis, which is inflammation of the gums, upper respiratory infections like colds, skin infections like impetigo and ear infections, or otitis media.
Okay, so just kind of the normal stuff that kids get.
Yeah, exactly.
Are there any other infections that are a little less common but still associated?
Yeah, so some of the less common ones are things like just the common cold, viral gastroenteritis, which is like the stomach flu, other types of skin infections, stomatitis, which is just like a general inflammation of the mouth, and sinusitis. And it's worth mentioning that while serious infections are uncommon, they can occur. So those would be things like cellulitis, abscesses, urinary tract infections, and very rarely things like sepsis, pneumonia, or even brain abscesses.
Oh, wow.
But those are very rare.
Yeah.
And then there's also a reported case of pain-related periodontal disease.
Interesting.
Which is a disease of the gums.
Okay, so it sounds like it can be a little bit more serious than just kind of the average kid's sniffles.
Yeah, there is that potential.
Okay, but generally it's pretty mild.
Generally it's mild, yeah.
Okay. And does this usually affect the child's growth and development at all?
Not typically, no.
Okay.
So they might have more febrile illnesses than other kids. But it usually doesn't affect their growth and development.
Okay, that's good to know.
Yeah.
So if we understand what it is and kind of how it shows up, what's the usual way to manage pain?
So the focus of management with primary AON is really just on managing any infections that arise.
Okay.
Because it's expected to resolve on its own.
Right.
We don't really do anything to try to cure the low neutrophil count.
Okay. So are there any steps taken to prevent those infections?
Yeah. So if a child has frequent mild infections, their doctor might consider putting them on prophylactic antibiotics.
Okay.
Usually that's trimethoprim and sulfamethoxazole.
Gotcha.
But the benefit of that is mostly anecdotal.
Okay.
So there's not like a lot of great evidence to support it.
Right.
But it's something that is done sometimes.
Okay.
A lot of times if the child is well and not having that many infections, then we don't really do anything to treat the low neutrophil count specifically because we know that it's going to recover on its own.
Right.
And then in more severe cases of primary AON, especially if the child is experiencing frequent or significant infections, we might use GCSF periodically, which is granulocyte colony stimulating factor.
Gotcha.
And that helps to increase the production of neutrophils.
So that's kind of a more severe case scenario.
Exactly.
Okay, so that covers primary AN.
Yep.
Let's move on to the secondary version, or SAIN. How is secondary autoimmune neutropenia different from primary?
So SAIN is different from PAIN in a few key ways.
Okay.
The biggest difference is probably who it affects.
All right.
So we talked about PAIN being in infants and toddlers.
Right.
SAIN is going to occur in an older age group.
Okay.
The average age of onset is around 10 years old.
Okay, big difference.
Yeah, huge difference.
Okay.
And also importantly, SAIN doesn't just happen on its own.
Okay.
It's secondary to some other underlying medical condition.
Oh, interesting. Okay, so what kind of things are we talking about here?
So it can be a lot of different things.
Okay.
It can be systemic autoimmune diseases, like lupus or rheumatoid arthritis.
Okay.
It can be infections, neoplasia, which is like cancers or other types of growths.
Gotcha.
It can happen after transplantation, like an organ transplantation or bone marrow transplantation.
Okay.
It can be from certain medications, or it can be seen in people with immunodeficiency disorders.
Wow. So it's kind of a whole different ball game than the primary.
Yeah, completely different.
Okay. And SAIN is more common in girls as well.
That's right. Yeah.
Okay. So what are some of the key things that make SAIN different from PAIN clinically?
So one of the biggest differences is that there's a much higher risk of serious infections with SAIN. So those would be things like sepsis, pneumonia, skin and soft tissue abscesses, things like that.
Okay.
And one study showed that about 40% of patients with SAIN had a severe infection.
Okay.
Compared to only 12% of patients with PAIN.
Huge difference.
Yeah, big difference.
Wow.
And another big difference is that spontaneous recovery is really rare in SAIN.
Okay.
So one study showed that only about 7.7% of cases had spontaneous recovery.
Wow. Okay. So big difference in the outcome there.
Yeah.
What are some other things that are kind of the hallmarks of SAIN that make it different from PAIN?
A few other things. Yeah. It's often associated with other cytopenias, which basically means low blood counts affecting other cell lines.
Gotcha.
So that would be things like ITP, which is immune thrombocytopenia, where your platelet count is low. Okay. Or AIHA, which is autoimmune hemolytic anemia, where your red blood cells are being destroyed.
Gotcha.
Some patients with SAIN might also have organomegaly, which is an enlarged liver or spleen or both.
Right.
That's not typically seen in PAIN.
Okay.
And then the last difference is that the type of antibodies that are involved tend to be different. Okay. So in SAIN, we often see antibodies that are directed against pan-Fc gamma R3b. Okay. Whereas in PAIN, it's more commonly anti-NA alloantigens.
Gotcha. So the antibody profiles are generally different.
Exactly.
Okay. And given that there are these higher risks involved with secondary NAN, and it's kind of tied into these other conditions, how is that usually managed?
So because there's a higher risk of serious infections with SAIN and because there's a low chance of spontaneous recovery.
We tend to take a more active approach to managing it.
Okay.
So prophylactic antibiotics are frequently needed to help prevent those infections. And then regular treatment with GCSF is also common to help maintain a higher neutrophil count.
Okay. So that's really where you see that contrast between the primary and the secondary.
Exactly.
Yeah. One thing that the sources mentioned is that it can be really hard to tell AIN apart from congenital neutropenia. Why is this a diagnostic challenge?
Yeah, so it can be really tricky to differentiate those two.
Okay.
Because they can both present with a very similar low absolute neutrophil count, or ANC.
Okay.
So both AIN and severe congenital neutropenia can present with ANCs that are below that threshold that we talked about.
Right.
So if you're just looking at that number alone, it can be really hard to tell them apart.
Gotcha. So the neutrophil count itself isn't enough.
Right, exactly.
What are some other things that make it tough to tell them apart? So the initial presentations can also be very similar.
Okay.
So while primary AMPIting tends to present with those mild to moderate infections,
right,
and severe congenital neutropenia tends to present with more frequent and severe infections, there can be some overlap. Especially early on, or in milder forms of congenital neutropenia.
Right.
And then also, even though AMIN is autoimmune, and you might think that neutrophil antibodies would be present in all cases, that's not actually true.
Okay.
So sometimes we don't detect antibodies in cases of AMI. And to make things even more confusing, neutrophil antibodies have actually even been found in some cases of confirmed congenital neutropenia.
Oh, wow. Okay, so it's not a foolproof diagnostic criteria.
Not at all.
So how do they go about trying to differentiate these then if it's so difficult?
So when severe congenital neutropenia is suspected, especially if there's a family history of it, or if the child is having a lot of severe recurrent infections, then we're going to do genetic testing to try to identify the specific genetic mutation that's causing the neutropenia.
So that's really the only way to know for sure.
Yeah, pretty much.
Okay. And you've mentioned the neutrophil antibodies several times.
Right.
Let's talk about those specifically a little bit more.
Okay.
So if AIN is classified as autoimmune, are the antibodies always there?
So that's a really important point.
Okay.
Even though AIN is considered autoimmune, you don't always find detectable antibodies against neutrophils.
Okay.
And actually, cases of chronic neutropenia where we don't find any neutrophil antibodies are sometimes called chronic idiopathic neutropenia, or CIN.
Gotcha.
But the really important thing to understand is that for primary AIN, whether or not those antibodies are detected doesn't really change the expected outcome or the way that we manage it. So kids with primary AIN still have that same likelihood of spontaneous recovery regardless of their antibody status. And it's also important to note that the ability to detect those antibodies can vary depending on the lab technique that's being used.
Gotcha.
And as we talked about before, those antibodies have even been found in some cases of congenital neutropenia. So they're really not a foolproof way to diagnose AIN.
Okay, so given that it's not like the defining feature,
Yeah.
what's the most important thing for parents and caregivers to understand about this?
I think what's really valuable is to clearly explain the natural history of primary AIN to parents and caregivers.
Okay.
So, you know, a low neutrophil count can be really scary to hear about.
Absolutely.
So really kind of going through and explaining, you know, this is the typical age that it starts.
Right.
This is the type of infections that we see. These kids have a really high chance of recovering completely before the age of 5. That can really help to reduce the anxiety that parents and caregivers are feeling.
Absolutely.
It also kind of validates their experience if their child has had some of these mild infections.
Right.
And it just kind of gives them more confidence in the diagnosis.
Absolutely.
And in the recommended approach, which is often just to monitor and not necessarily treat.
Yeah, it just makes them feel like, okay, we're not overreacting.
Exactly.
This is actually what this is.
Exactly.
That makes perfect sense. And yeah, managing those expectations and making sure that everybody feels heard and reassured, I think is so important.
Absolutely.
So are there any specific precautions that should be taken for kids with the AM, whether it's primary or secondary?
Yeah, so for both primary and secondary, AIM, good dental hygiene, is super important to help prevent those oral infections.
Makes sense.
And then it's also really important for both patients and caregivers to be on the lookout for any signs of infection. So, you know, in primary AN, where those infections are usually mild and localized, you're still going to be looking out for things like mouth sores, gum inflammation, upper respiratory symptoms, skin infections, things like that.
Gotcha.
And then with secondary AIN, where there's that higher risk of serious infections, you're going to be even more vigilant about watching for those signs.
Absolutely.
And then the last thing is just to make sure that they're following medical advice about any prescribed treatments, whether that's prophylactic antibiotics or GCSF or anything else.
So to kind of sum all of this up in a nice little package,
Okay.
can we just go over the main timeline differences one last time
Absolutely.
between PAIN and SAIN?
Yeah. So primary AN tends to start in infancy and toddlerhood.
Right.
So between 4 and 28 months.
Right.
And most cases are going to resolve before the child turns 5.
Gotcha.
Secondary AN, on the other hand, usually starts in older childhood.
Right.
The average age of onset is around 10 years old.
All right.
And spontaneous recovery is rare.
Gotcha. Okay. So the big takeaway here is that primary autoimmune neutropenia in those younger kids is generally a benign condition.
Right.
It has a really good chance of resolving on its own.
Exactly.
Versus secondary autoimmune neutropenia, which happens in the older kids, usually is associated with some other kind of illness and can be a little bit more risky.
Absolutely.
In terms of complications.
Yeah.
Would you agree with that summary?
That's a great summary.
Yeah. Okay, good.
And I think the other important thing to remember is that even though the term autoimmune is in there, the presence of detectable antibodies is not the defining factor in primary ANAN. So it's really more about that clinical picture, the age of onset, the expected course.
Gotcha.
So that's really more important than whether or not those antibodies are present.
Okay, so really understanding those key differences between the two types, I think, is the most important thing here.
Absolutely.
And especially with the PAIN, making sure that people aren't overly concerned.
Exactly.
Because the outcomes tend to be good.
That's right.
Awesome. Well, any final thoughts before we wrap up?
I think just, this was a great discussion.
Yeah.
And, really understanding these distinctions is so crucial for being well-informed and for making sure that we're managing these cases appropriately.
For sure. For sure. Well, on that note, I will leave you with one final thought to kind of ponder.
Okay.
There were some hints in the research about potential roles of the gut microbiome and genetic factors in AIN.
Yeah.
So where do you think that future research should go?
That's a great question.
Yeah.
I think that's a really interesting area.
Yeah.
And I think, exploring those connections could lead to some really important advances.
For sure. And for anybody listening who's interested in digging deeper.
Absolutely.
We encourage you to check out the sources that we use for today's deep dive or consult with your medical professional. Thanks for joining us.
Thanks for having me.
We'll see you next time.
Sounds good.